Good morning, my friends. I'm Dr. Armen. So that is Dr. Y, Professor Y. Dr. Armen Astvatsatryan from Yerevan, Armenia. And today we will talk about pericarditis. Actually, this is a series of lectures for medical students. Okay, so pericarditis. What is pericarditis? Pericarditis, as a name, is an inflammation of the pericardium, often with fluid accumulation. Pericarditis may be caused by many disorders. For example, infection, myocardial infarction, trauma, tumors, metabolic disorder, but it's often idiopathic. Symptoms include chest pain or tightness, often worsened by deep breathing. Cardiac output may be greatly reduced if cardiac tamponade or constrictive pericarditis develops. Diagnosis is based on symptoms of friction rub, electrocardiographic changes, and evidence of pericardial fluid accumulation on X-ray or echocardiogram. Finding the cause requires further evaluation. Treatment depends on the cause, but general measures include analgesics, anti-inflammatory drugs, colchicine, and rarely surgery. Colchicine. Okay, and rarely surgery, colchicine. Pericarditis is the most common pericardial disorder. So congenital pericardial disorders are rare. Okay. About anatomy. So the pericardium has two layers. The visceral pericardium is a single layer of mesothelial cells that is attracted to the myocardium. Falls back, reflects on itself over the origin of the great vessels and joins with a tough, fibrous layer to envelop the heart as the peripheral pericardium. The sac created by these layers contains a small amount of fluid, less than 25 to 50 milliliters, composed mostly of an infiltrated or plasma. The pericardium limits distension on the cardiac chambers and increases the heart's efficiency. The pericardium is richly innervated with sympathetic and somatic afferents. Stretch-sensitive mechanoreceptors sense changes in cardiac volume and tension and may be responsible for transmitting pericardium pain. The phrenic nerves are embedded in the parietal pericardium and vulnerable to injury during surgery on the pericardium. So, pathophysiology of pericarditis. Pericarditis may be acute, subacute, of course, and chronic. Acute pericarditis develops quickly, causing inflammation of the pericardial sac and often a pericardial effusion. Inflammation can extend to the epicardial myocardium, myopericarditis. Adverse hemodynamic effects and rhythm disturbance are rare, although cardiac tamponade is possible. Acute disease may completely resolve and reoccur up to 30% of acute cases or become subacute or chronic. These forms develop more slowly. Their prominent feature is effusion. Subacute pericarditis occurs within weeks to months of an inciting event. Chronic pericarditis is defined as a pericarditis persisting more than 6 months. Pericardial effusion is accumulation of fluid in the pericardium. The fluid may be serous fluid, sometimes with fibrin strands, serous fluid, blood, pus, or chyle. Cardiac tamponade occurs when a large pericardial effusion impairs cardiac filling, leading to low cardiac output and sometimes shock and death. If fluid, usually blood, accumulates rapidly, Even small amounts, for example 150 milliliters, may cause tamponade because the pericardium cannot stretch quickly enough to accommodate it. Slow accumulation of up to 1,500 milliliters may not cause tamponade. Loculated effusion may cause localized tamponade on the right or left side of the heart. Occasionally, pericarditis causes a markedly thickening and stiffening of the pericardium, so-called constrictive pericarditis. Actually, constrictive pericarditis, which is now less common than in the past, results from marked inflammatory fibrotic thickening of the pericardium. Sometimes the visceral and parietal layers adhere to each other or to the myocardium. The fibrotic tissue often contains calcium deposits. The stuff thickened pericardium markedly impairs ventricular filling, decreasing stroke volume and cardiac output. Significant pericardial fluid accumulation is rare. Rhythm disturbances is common. The diastolic pressures in the ventricles, atria and the venous beds becomes virtually the same. Systemic venous congestion occurs, causing considerable transudation of fluid from systemic capillaries with dependent edema and later ascites. Chronic elevation of systemic venous pressure and hepatic venous pressure may lead to liver scarring, called cardiac cirrhosis. Constriction of the left atrium, the left ventricle, or both may elevate pulmonary venous pressure. Occasionally, pleural effusion develops. There are several variants of constrictive pericarditis. Chronic constrictive pericarditis, usually requiring pericardiectomy as definitive treatment. Subacute early stage, constrictive pericarditis developing weeks to months after an inciting injury and managed initially with medical therapy. Treatment constrictive pericarditis, typically subacute, is that which resolves spontaneously or after medical therapy. Effusion of constrictive pericarditis characterized by pericardial constriction involving the visceral pericardium with significant pericardial effusion, sometimes requiring treatment for cardiac tamponade. Etiology. So acute pericarditis result from infection, autoimmune or inflammatory disorder, uremia, trauma, myocardial infarction, cancer, radiation therapy, or certain drugs. Infectious pericarditis is most often viral or idiopathic. Purulent bacterial pericarditis is uncommon but may follow infective endocarditis, pneumonia, septicemia, penetrating trauma, or cardiac surgery. Often the cause cannot be identified, called nonspecific or idiopathic pericarditis, but many of these cases are probably viral. Acute myocardial infarction causes 10 to 15% causes of acute pericarditis. Post-myocardial infarction syndrome, Dressler syndrome, is a less common cause now, occurring mainly when reperfusion with percutaneous transluminally coronary angioplasty or thrombolytic drugs is ineffective in patients with transmural transmural infarction. But it's actually very questionable. Anyway, so pericarditis occurs after pericardiotomy, called post-pericardiotomy syndrome, in 5 to 30% of cardiac operations. Post-pericardiotomy syndrome, post-myocardial infarction syndrome, and traumatic pericarditis comprise the post-cardiac injury syndromes. Subacute pericarditis is a prolongation of acute pericarditis and thus has the same causes. Some patients have transient constriction occurring days to weeks after recovery from acute pericarditis. Chronic pericarditis with pericardial effusion or chronic constrictive pericarditis may follow acute pericarditis or almost any etiology. In addition, some cases occur without antecedent acute pericarditis. Chronic pericarditis with large effusion, serosanguinous or bloody, is most commonly caused by metastatic tumors, most often by lung carcinoma, breast carcinoma, sarcoma, melanoma, leukemia, or lymphoma. Hypothyroidism may cause pericardial effusion and cholesterol pericarditis. Cholesterol pericarditis is a rare disorder that may be associated with myxedema, in which a chronic pericardic effusion has a high level of cholesterol oral triggers inflammation and pericarditis. Sometimes no cause of chronic pericarditis is identified. Transient constrictive pericarditis is most commonly caused by infection or post-pericardiectomy inflammation or is idiopathic. Fibrosis of the pericardium, sometimes leading to chronic constrictive pericarditis, may follow purulent pericarditis or accompany a connective tissue disorder. In connective tissue disorder, yeah. In older patients, common causes are malignant tumors, myocardial infarction, tuberculosis. Hemopericardium, accumulation of blood within the pericardium, may lead to pericarditis or pericardial fibrosis. So common causes include chest trauma, iatrogenic injury, for example, resulting from cardiac catheterization, pacemaker insertion, central venous line placement, and rupture of thoracic aortic aneurysm. Symptoms and signs. Okay, let's talk about symptoms and signs. Some patients present with symptoms and signs of inflammation, acute pericarditis. Others present with those of fluid accumulation, pericardial effusion, or constriction. Symptoms and signs vary depending, of course, on the severity of inflammation and the amount rate of fluid accumulation. Even a large amount of pericardial fluid may be asymptomatic if it develops slowly, for example, over months. Acute pericarditis tends to cause chest pain, sometimes with dyspnea. Yes, chest pain and pericardial rub. Actually, yes, let's try to do it. Sometimes with dyspnea. The first evidence can be tamponade with hypertension, shock, or pulmonary edema. Actually, concerning audio sounds, you can find in my lectures, so auscultation. And you can find them pericardial friction rub. So go with this link to hear that. But let's maybe I'll try to put once again pericardial friction rub, please. Yeah, pericardial friction rub, if it's possible, of course. Yes, please. Be careful now. Once again, please. Pericardial friction rub. Okay, once again, the last time. Okay. Very good. So you hear pericardial friction rub. Because the innervation of the pericardium and myocardium is the same, the chest pain of pericarditis is sometimes similar to that of myocardial ischemia, to myocardial inflammation, or even ischemia. Dull or sharp pericardial substantial pain may radiate to the neck, trapezius ridge, especially the left, or shoulders. Pain ranges from mild to severe, unlike ischemic chest pain. Pain due to pericarditis is usually aggravated by thoracic motion, cough, breathing, or swallowing food. It may be relieved by sitting up and leaning forward. Tachypnea and non-productive cough may be present. Fever, chills, and weakness are common. In 15 to 25% of patients with idiopathic pericarditis, symptoms recur intermittently for months or years. Recurrent pericarditis. The most important physical finding is triphasic or a systolic and diastolic pericardial friction rub that we heard up above. However, the rub is often intermittent and evanescent, and may be present only during systole or less frequently only during diastole. If no rub is heard with the patient seated and leaning forward, auscultation may be attempted by listening with the diaphragm of the stethoscope while with the patient is on all fours. Sometimes the pleural component to the rub is noted during breathing, which is due to inflammation, or the pleural adjacent to the pericardium. Pericardial effusion. Okay. So pericardial effusion is often painless, but when it occurs with acute pericarditis, pain may be present. Considerable amounts of pericardial fluid may muffle our sound. Increases the area of cardiac dullness and change the size and shape of the cardiac silhouette. A pericardial rub may be heard with large effusions. Compression of the base of the left lung can decrease breath sounds. Hard near the left scapula and causes crackles. Arterial pulse, jugular venous pulse, and blood pressure are normal unless intrapericardial pressure increases substantially, causing tamponade. In the post-myocardial infarction syndrome, pericardial effusion can occur with fever, friction rub, pleurisy, pleural effusions, and joint pain. Pleurisy, and joint pain. So the pleurisy. The syndrome usually occurs within 10 days to 2 months after myocardial infarction. It's usually mild but may be severe. Occasionally, the heart ruptures post-myocardial infarction, causing hemopericardium and tamponade, usually 1 to 10 days post-myocardial infarction and more commonly in women. Cardiac tamponade. So the clinical findings are similar to those of cardiogenic shock: decreased cardiac output, low systemic arterial pressure, tachycardia, and dyspnea. Neck veins are markedly dilated. Severe cardiac tamponade is nearly always accompanied by a fall of more than 10 mm hydrargyrum in systolic blood pressure during inspiration, pulsus paradoxus. In advanced cases, pulse may disappear during inspiration. However, pulsus paradoxus can also occur in chronic obstructive pulmonary disease, bronchial asthma, pulmonary embolism, right ventricular infarction, and non-cardiogenic shock. Heart sounds are muffled unless the effusion is small. Loculated effusions are eccentric, or localized hematoma may cause localized tamponade, in which only selected cardiac chambers are compressed. In these cases, physical, hemodynamic, and some echocardiographic signs may be absent. Constrictive pericarditis. Fibrosis or calcification rarely causes symptoms unless constrictive pericarditis develops. The only early abnormalities may be elevated ventricular diastolic, atrial, pulmonary, and systemic venous pressures. Symptoms and signs of peripheral venous congestion, for example, peripheral edema, neck vein distension, hepatomegaly, may appear with an early diastolic sound. Pericardial knock, often best heard during inspiration. This sound is due to abrupt slowing or diastolic ventricular filling by the rigid pericardium. So let's listen diastolic knock, but once again, if you wanna, so go to auscultation, my lecture. You can find this in YouTube or one of the podcasts, auscultation, and let's hear diastolic knock. Let's try to listening, make it more louder, please. Yes, diastolic knock, please. Yes, diastolic knock, ladies and gentlemen. Not good quality at all, huh? Okay, once again, diastolic knock, please. Yeah, once again. Okay, last time. Yeah, it was diastolic knock. So ventricular systolic function, based on ejection fraction, of course, is usually preserved. Prolonged elevation of pulmonary venous pressure results in dyspnea, particularly during exertion, and orthopnea. Fatigue may be severe. Distension of the neck veins with a rise in venous pressure during inspiration, Kussmaul sign is present, it's absent in a tamponade. Pulsus paradoxus is rare and is usually less severe than in tamponade. Lungs are not congested unless severe left ventricular constriction develops. So diagnosis, let's talk about diagnosis of pericarditis. Electrocardiography, yeah, why not? And check X-ray, echocardiography, of course. Test to identify cause, pericardial fluid aspiration, pericardial biopsy. ECG and chest X-ray are done. Echocardiography is done to check for effusion, particularly loculated effusion with localized tamponade, which because of its atypical manifestations may not be suspected, and which may be suggested by indirect findings such as compression of chambers and characteristic respiratory variations, cardiac filling abnormalities, and wall motion abnormalities characteristic of myocardial involvement. Blood tests may detect leukocytosis and elevated erythrocyte sedimentation rate, but these findings are non-specific. So acute diagnosis of acute pericarditis. Diagnosis is based on the presence of the following clinical findings and ECG abnormalities, which are not always present in all cases. Characteristic chest pain, pericardial rap, ECG abnormalities, pericardial effusion. Serial ECGs may be needed to show abnormalities. The ECG in acute pericarditis may show abnormalities confined to ST and PR segments and T waves, usually in most leads. ECG changes in lead AVR are generally in the opposite direction of other leads. Unlike myocardial infarction, acute pericarditis doesn't cause reciprocal depression in ST segments, except in leads AVR and AV1. Actually, reciprocal changes we can see just in first hours of myocardial infarction. And there are no pathologic QAs on the second day, for example. ECG, as in myocardial infarction we see. ECG changes in pericarditis can occur in 4 stages, although not all stages are present in all cases. Stage 1, ST segments show upward concave elevation. The PR segment may be depressed. I don't know actually, could we show this? Okay, let's try. I'll try to show you, but anyway, it will be not a good quality. If you see some problems, you can see this. Okay, or you may put on pause this presentation. Yeah, and look it more carefully. Okay, let's try. Okay, let's try. So you understand this is not quality at all, but you can see, you can put on pause. So you see PR segment, you see ST segment, right? Some typical elevations, but not without reciprocal, no reciprocal changes. So yes, actually we can see this in acute pericarditis. Yes, you can put it on pause and see this. Yeah? Okay. So it was stage 1. Stage 2, ST segment return to baseline, T waves flatten. So flatten, not as the mountain, but flatten on isoline. As stage 3, T waves are inverted throughout ECG to negative. And T wave inversion occurs after the ST segment has returned to baseline and thus differs from the pattern of acute ischemia or myocardial infarction. Actually, it's a question about myocardial infarction, but anyway. And stage 4, T wave changes resolve. Echocardiography in acute pericarditis typically shows an effusion which helps confirm the diagnosis, except in patients with purely fibrinosis acute pericarditis, in whom echocardiography is often normal. Findings indicating myocardial involvement include new focal or diffuse left ventricle dysfunction. MRI can detect the present severity and acute of pericardial inflammatory, but is generally not required to diagnose acute pericarditis. Because the pain of pericarditis may resemble that of acute myocardial infarction or pulmonary infarction, additional tests, for example, serum cardiac marker measurements, lung scan, may be required if the history and ECG findings are atypical for pericarditis. Troponin is often elevated in acute pericarditis due to epicardial inflammation, so it cannot discriminate between pericarditis acute infarction and pulmonary embolism. So once again, if troponin is elevated, is a sign of necrosis. So due to myocardial infarction, not due to non-myocardial infarction, pericarditis, myocarditis, endocarditis, troponin is a sign of necrosis of the myocytes, cardiomyocytes. Very high levels of troponin may indicate myopericarditis. The CKMB fraction, creatinine kinase muscle blood band isoenzyme level, which is less sensitive than the troponin level, is usually normal in acute pericarditis unless myocarditis is also present. Post-pericardiotomy and post-myocardial infarction syndromes may be difficult to identify and must be distinguished from recent myocardial infarction, pulmonary embolism, and pericardial infection after surgery, pain, friction, rub, and fever appearing 2 weeks to several months after surgery, and a rapid response to aspirin, non-steroidal anti-inflammatory drugs, colchicine, colchicine, or corticosteroids, its aid diagnosis. About pericardial effusion. Diagnosis is suggested by clinical findings, but often is suspected only after finding an enlarged cardiac silhouette on chest X-ray. On ECG, QRS voltage is often decreased and sinus rhythm remains in about 90%. Of patients with large chronic effusions, the ECG may show electric alternance, that is, PQRS or T wave amplitude increases and decreases on alternate beats. Electric alternance is associated with variation in cardiac position, swinging heart. Yeah. Echocardiography estimates the volume of pericardial fluid identifies cardiac tamponade, acute myocarditis, and heart failure. It may overestimate its size, and it's not a first-line test to evaluate possible pericardial effusion. Patients with a normal ECG, small, so less than 50 milliliters effusion, and no suspicious findings from the history and examination may be observed with serial examination and echocardiography. Other patients must be evaluated further to determine etiology. Constrictive pericarditis. Diagnosis may be suspected on clinical ECG, chest X-ray, and Doppler echocardiography. Findings, but cardiac catheterization, computer tomography, or actual MRI are usually required. Rarely, right heart biopsy is needed to exclude restrictive cardiomyopathy. ECG changes are non-specific. QRS voltage is usually low. T waves are usually non-specifically abnormal. Atrial fibrillation occurs in about 1/3 of patients. Atrial flutter is less common. Lateral chest X-ray often shows pericardial cardiac calcification best, but the finding is non-specific. Echocardiography also is non-specific. When the right and left ventricular filling pressures are equally elevated, Doppler echocardiography helps distinguish constrictive pericarditis from restrictive cardiomyopathy. During inspiration, mitral diastolic flow velocity usually falls more than 25% in constrictive pericarditis, but less than 15% in restrictive cardiomyopathy. In constrictive pericarditis, inspiratory tricuspid flow velocity increases more than it normally does, but it does not do so in restrictive cardiomyopathy. Determining tissue velocities as the mitral annulus may be helpful when excessively high left atrial pressure, blunts respiratory variation in transvalvular velocities. Mitral annual velocities, especially at the septal location, increase in constrictive pericarditis. They decrease in restrictive cardiomyopathy. Presence of a septal bounce, shift of the intraventricular septum towards the left ventricle during inspiration and away from the left ventricle during expiration, and hepatic vein expiratory diastolic reversal, which occurs due to reduced filling of the right ventricle, can also be visible in constrictive pericarditis. Respiration-related ventricle septal shift preserved or increased medial annual velocity, and hepatic vein expiratory diastolic reversals collectively are referred to as the Mayo Clinic criteria. But each factor is independently associated with constrictive pericarditis. A cardiac catheterization, right to left-sided, is done of clinical and electrocardiographic findings, such as constrictive pericarditis. Cardiac catheterization helps confirm and quantify the abnormal hemodynamics that define constrictive pericarditis. Mean pulmonary artery occlusion pressure, pulmonary capillary wedge pressure, pulmonary artery diastolic pressure, right ventricular and diastolic pressures, and mean right atrial pressures are roughly equal, or all about 10 to 30 millimeter hydrargyou. The pulmonary artery and right ventricular systolic pressures are normal or modestly elevated, so that pulses pressures are small. In the atrial pressure curve, X and Y descents are typically accentuated. In the ventricular pressure curve, a diastolic dip occurs as the time of the rapid ventricular filling. During peak inspiration, right ventricle pressure increases when the left ventricle pressure is lowest, sometimes called mirror image discordance, suggesting increased ventricular interdependence. Because ventricular filling is restricted, ventricular pressure tracing show a sudden dip followed by a plateau resembling a square root sign. Is early diastole, in early diastole, yeah. Square root sign, yeah. Measuring these changes requires simultaneous right and left heart cardiac catheterization using separate transducers. These hemodynamic changes almost always occur with significant constrictive pericarditis but may be masked during hypovolemia. Right ventricular systolic pressure of more than 50 mm retrarguum often occurs in restrictive cardiomyopathy, but less often in constrictive pericarditis. When the pulmonary artery occlusion pressure equals the right atrial mean pressure and early diastolic dip in the ventricular pressure curve occurs with large X and Y waves in the right atrial curve, either disorder may be present. Computer tomography or MRI can identify pericardial thickening more than 5 millimeters, pericardial thickening more than 5 millimeters with typical hemodynamic changes assessed by echocardiography and catheterization can confirm constrictive pericarditis. When no pericardial thickening or fluid is seen, the diagnosis of restrictive cardiomyopathy is favored but not proved. A normal pericardial thickness doesn't exclude constrictive pericarditis. Increased T2 weighted short T1 inversion recovery, a signal and late gadolinium enhancement on cardiac MRI can document active inflammation and resolution of constriction in response to anti-inflammatory therapy, whereas their absence suggests chronic constrictive pericarditis that is unlikely to be responsive to medical therapy. The degree of late gadolinium enhancement of the pericardium may be especially helpful in identifying patients in whom constriction will reverse or resolve. I'll say, okay, I think it's enough for today, for first part of pericarditis. Thank you for your attention. So don't forget to follow and subscribe our channel, Dr. Y. Yes, and please don't forget to make your donations, because without your donates, can't exist actually. So how to make these donations you can find in description of this video in YouTube or on description of this audio in your podcast. Okay, bye. See you.